Welcome everyone, and welcome to Viewpoint the Conversation, and yes, welcome to Glaucoma on Radio, your trusted platform for a conversation that protect not just your voice but also your vision. Well, ladies and gentlemen, today we are focusing on a condition that many people have heard about. And right here on Solid 100.9 FM, we always want to make sure that the right informations go out there to you all listening. But from all of the information that we share about, very few people truly understand what we are about to talk about, and that is glaucoma. Now, here is something very important. Glaucoma is not just one disease. It is a group of eye conditions with different types, each with its own risks, progression, and impact on your eyes. Some develop quietly over time without symptoms, while others can come suddenly and cause rapid vision loss if not treated immediately. So, this morning, our focus is one name, different dangers, and we are looking at the types of glaucoma. And in this discussion, we will be understanding these differences and also how early detection can play a vital role in saving your vision. And to help us unpack all of this important discussion, we have with us an expert from the Eye Specialist Hospital, TESH, Dr. Obina Shiwobi. Doc, good morning and good to have you.
Good morning, people. The buying the alone.
Right, Doc, and just for the purpose of those who are listening for the very first time, let's understand the basics of glaucoma. Let's begin with the foundation. What exactly is glaucoma in simple terms, and why is it important for people to understand that glaucoma is not just one single disease?
Yeah, thank you so much. We've said so many things about glaucoma, and why we keep re-emphasizing the importance of the disease is because it is the commonest cause of irreversible blindness. Having said that, and by extrapolations, we found out that it is commonest among the blacks and people of Hispanic descent, but commonest among the blacks. And then, I said again, the studies done, it's found to be more or most in West Africa, of when it comes to Africa. And then in the Nigerian study, it was found to be commonest among the Igbos. Not only the disease, but its complications of visual impairment and blindness. And it's a disease that affects the optic nerve. The nerve is a second cranial nerve, and it's called the nerve of vision. If anything, it is the nerve that connects the eyeball to the occipital part of the brain. That part of the brain that interprets what you see. What the eye does is just to conduct light impulses, and these nerves take them to the brain for interpretation. So if anything happens to that particular nerve, light impulses come, but no conduction to the brain for interpretation, and therefore the patient is said to be blind because he can't see anything. So it is just a very important issue. We're bringing it up to our people, and I want to also, in this same vein, thank the Solid FM for this social responsibility to our people, allowing us come and have conversation with them every Friday morning, because I tell you, there are about say more than 70% of people who have glaucoma now who don't even know they have glaucoma, because its symptoms come late, and we call it the silent thief of sight. Silent in the sense that it comes, it is not symptomatic initially, and then vision begins to depreciate. By the time it becomes symptomatic, it's almost like an advanced glaucoma. By then we're struggling. And then for those who come for checkup, they are easily found on time to have glaucoma, and then treatment is quite easy, and they're most amenable to therapy. Unlike those who come when it is late, when the disease has already done so much harm, and then you are struggling to maintain intraocular pressure. So it is an important issue that people should know this. So the foundation is that this is the commonest cause of irreversible blindness and irreversible visual impairment. Underline the word irreversible. Because the optic nerve is an offshoot of the brain, and brain cells don't regrow when they die. So it is this importance that we are bringing to our people, that the disease called glaucoma, it does not inform you that it has come, and that it can happen to everybody.
All right.
Thank you.
It can happen to everybody. Well, ladies and gentlemen, just so you know, we are discussing one name, different dangers, and we are going to be looking at the types of glaucoma. And yes, it is Chibika James as well as Dr. Obinna. She will be right here in the studio. Well, Doc, without wasting the people's time, we are here to talk about the types of glaucoma. Can you walk us through the main types of glaucoma?
Okay, thank you, Chibike. The most important thing is, like you rightly said, it is a group of diseases, and the common factor is that they cause optic neuropathy. That is, they all affect the optic nerve, and they are legion. So let us start. So different classifications of glaucoma. It can be classified based on age. It can be classified based on, is there a secondary cause, or he just came out on his own without a known cause. Very importantly, it can also be classified according to the drainage angle, whether it is open or closed. Now, very importantly, let us say that glaucoma can affect a child born today. So a child who comes down with glaucoma in the first month of life is called neonatal glaucoma. A child can also come down with glaucoma within the first year of life, and that one is called infantile glaucoma. And then...
So even infants have it?
Yes, infants have it. That's a neonate. Neonate is 4 weeks of life.
Wow.
So if it can happen to the neonates now, 4 weeks of life, it can also happen to the first year. So first year, then it can also happen within the first 3 years, what we call congenital glaucoma. People say, let me use our people's balance, it is a follow-come, so it can happen within these first 3 years. Is not called congenital glaucoma. Now it can also occur between 3 to 18 years. In some texts, in some literature, they say 3 to 16 years, but above 3 years to 18 is taken to be childhood glaucoma. So it can also occur in children. And then from then 18 years to 40 years is said to be juvenile glaucoma. Now some people can also include juvenile to include from 3 to 40, below 40, that is above 3 years to below 40 years juvenile. But you have some people who say 3 to 18 is childhood, but juvenile encompasses all this. So having said this, it's good for us to realize that it is so important. Then above 40 is now said to be adult onset glaucoma. So very importantly too, this is going by age of onset. At the particular age it came. This same age also determines the kind of treatment you offer these patients. Now, very importantly, the commonest thing we do is to say whether there's a cause or there's no cause. That is, whether it's primary. Like when we say hypertension, we say primary hypertension. It means that there's no cause to the hypertension. So also when we say primary glaucoma, no known cause, something not just came on its own. Then we can also say secondary glaucomas. There's primary, no cause. Secondary, there's a cause. Something is causing it. As the patient has a Sturge-Weber syndrome and is coming up with it. Some people, have they abuse steroids, so they come up with it. They have also had trauma to that eye. They can also come up with it. There are also many litany of disease conditions that can also cause glaucoma. Now we commonly what we use is the angle, the opening of the angle. Now this drainage angle is so important because if it's not open, if it's not fully open, if you cannot see some structures, in that particular drainage angle of the
the open angle.
Yes, open angle. So we say if you cannot see some of them, cannot see from trabecular meshwork to the sclems canal, we say, oh, it is a closed angle.
Okay, can you explain what open angle
okay,
glaucoma
so
means?
when you're on a radio, so I'm trying to be less scientific.
I know, but the people would also want to have an in-depth understanding.
From the iris of the eyeball to the innermost part of the cornea, that's in the endothelial part of the cornea, that is the space for the angle.
Yeah.
So from the iris, you see the iris roots, you see the ciliary band, the ciliary body. Now you see the from there you see the scleral spore. From after that you now see the trabecular meshwork, then the sclems canal. So when we see the band, when we see the ciliary band, I mean this is quite open. Even when we see the scleral spore, it's also open. I mean, it's also open. Yeah. Now when you now see the trabecular meshwork, there's these two parts, pigmented and not pigmented part. The pigment part, that's okay. It's slightly open. And now you're looking at 4 quadrants: superiorly, laterally, close to the nose, that's nasally. Outside the nose is temporally, and then inferiorly. So you're looking at these 4 quadrants to see the extent of opening. Now, when you cannot see the trabecular meshwork, and you can only see the Schwabe's line, and you now say it is a closed angle. When you can't even see the closed angle, you say it's almost like a slit. So now this is where we place the glaucomas, apart from the age of onset. And then you also want to know, is there a secondary cause or is there no secondary cause? So now it is good to distinguish the type of glaucoma, because the investigations you do, as per the tests you run, and the treatment you offer, the counseling you offer, also depend on the type.
Yeah.
So it is quite important that we always say it is only appropriate to be seen by a medical doctor who has specialized in the eye, who is called an ophthalmologist, to attend to eye cases, especially when the patient comes down with glaucoma, because it will determine so much. You don't begin to treat somebody inappropriately. Yes, this drug is for glaucoma, but are you using it rightly? Are you using it rightly? Why will you use a drug called pilocarpine in a patient who already has an open angle? So it is only appropriate. And then there are, apart from treatments, apart from the intraocular, the topical medications, that's the eye drops we give, there's also laser, there's also surgery. For congenital, you don't even waste your time, you do surgery. I mean, for how long will you apply the eye drops in a child? Would that child allow to measure the pressure? No. The best and foremost thing is put the child to sleep, take the measurements of the cornea, take the intraocular pressure, then do what we call trap. It is a particular surgery that you do so that you can open the angles, because most of these children, they are born with a dysgenesis of that angle. So the angle is not open to drain aqueous. Aqueous is produced but not drained out appropriately or adequately. So it builds up the pressure, and the patient, when you see the child, the eyeball appears larger than normal. In some people, this is a beautiful eye. This child has eyes. No, the child may be sick. So if you begin to see your child's eye, the black of the eye, that's the cornea, enlarged beyond what you know is normal, or becomes suspiciously or turns bluish, part of the white of the eye, what we call this conjunctiva of the eye, begins to turn bluish, you are also worried. So what do you want to do? You want to appropriately go and make sure that an ophthalmologist sees this child as soon as possible. Now, many patients make the same mistake. They see this eye, the black of the eye enlarging, and they like appreciating it, like loving it. It is only when the back part of the eye, that black of the eye begins to turn whitish, they begin to run to see the ophthalmologist. No. At any point in time, these eyes do not look normal to you. Please come and see a doctor. It is only appropriate. You can even go back to the hospital where you had the child. I will tell you, oh, no, go and see an ophthalmologist. Something is happening. So it's just appropriate. Even for childhood glaucomas, the wisdom is also to do surgery. So you can see how it matters. But for the adult onset that is caught on time, you start with medications, because it is commonest, it is available, and it is the cheapest. and therefore you start with it. And then people are very cautious of surgery. So for a woman who wants to take in and she has glaucoma and she's already medication, the wisdom will be to do lasers. So you do lasers so that she will not be using drugs during pregnancy, because most of them are not safe during pregnancy. So this is why it's appropriate to see an ophthalmologist, and then so that appropriate diagnosis is made, cause of this glaucoma is assured, and then the appropriate treatment. Like I also say, it also affects the investigations. Like what you said, underline it, that some can come silently or gradually, some can come urgently, come with a sudden pain and everything, so it's just appropriate. And having said this, I think I have touched mostly the classification of glaucoma. In summary, it can be age onset through the angle, whether it is open or closed. Thirdly, that's whether it has a cause or there's no cause. Very importantly, when it come under the ones that do not have cause or causes, you also have what we call normal tension glaucoma.
Okay, but before we get to those causes, okay, there's something I want to understand, and I'm not sure you highlighted it, about the differences between this open angle glaucoma and the angle closure glaucoma.
Okay, so I said earlier that in open angle, the structures now from the iris, so the open angle is the distance or the space between the outermost part of the iris, to the innermost part of the cornea. So both, as they go down, come from what looks like a valley, and then they form the anterior angle chamber. Now, like I said, from the outermost, from the iris, if you can see the ciliary band, the ciliary body that produces aqueous, that means the angle is so open. And then remember I said you're going to look at the 4 quadrants. If you also see the scleral spore is also open. If you also see the pigmented part of the trabecular meshwork in at least 2 quadrants, it is also open. Now, when you can see this, and you're also seeing the Slem's canal, the Schwabe's line, not the Slem's line, the Schwabe's line, that means this is a closed angle. Then in some cases, it may not even be, that is, you just see the Schwabe's line all through. So it is only appropriate that at that time you now know that this is a closed angle and that this is an open angle. And now for patients who come with a closed angle, that you identify initially, and then the disc is not affected and the pressure is not raised, you call them primary angle closure suspect. These patients, you do laser iridectomy. That laser iridectomy opens the inferiormost part of the iris. Most peripheral part of the iris, you open it, you use lasers light and open it, create an opening. So there's now an opening between the anterior and posterior chamber. Because when these aqueous are produced, they come into the posterior chamber and they come to the iris, to the pupil into the anterior chamber. What have you done now? Having done that, if you're able to open up that, create that hole, the iridectomy, ectomy in medicine is like an opening, then when otomy is like an incision. So you remove part of the iris tissue, creating an opening, so that when these aqueous come, they come in immediately. And having done that, you see that the iris recedes backwards. You do understand? Instead of bowing out, closing the angle. Once you do it, the iris comes backwards, and then that opens the angle the more. So that can save. Then for those who it has not affected the optic disc, but it has caused a raised pressure, of course, that's a primary angle closure. You can start with medication to bring it down, but most importantly, by the time you do that laser peripheral iridectomy, the pressures come down, because that's part of the iris that bowed forward and was occluding the angle. Having created that iridectomy, it recedes backwards. Then the angle is now partly open, mostly open. So,
All right.
so yeah, go ahead.
Okay, coming to Nigeria, okay, because we are in Nigeria and we need to understand this very, very well. I'm trying to get us to the differences in the dangers as well as the progression of these glaucomas that you have explained, okay. Which type of glaucoma is most common, especially in Nigeria?
Yes. Okay. Okay. Thank you so much, my brother. See, the commonest anywhere in the world is the primary open angle glaucoma. Now, in Nigeria, that is the commonest too.
Ah.
Yes. In India, in the Asian world, they have more of primary angle closure.
Okay.
Glaucoma. Then, among the Eskimos, the shorter the person, most times the narrower the angle. In patients who have, that is the risk factor, patients who have hypermetropia, what we call long-sightedness, the eyeballs are smaller, also the angles are smaller. In women, they have the angles of the men are wider than that of the women. And with age, as the age, the angles narrow, So that's why it may be a reason why, above the age of 40, a lot of factors come in, but it's also as you age, the angles narrow, unlike in the juvenile days. So for here, we talked about one, we have more of primary open angle glaucoma than the primary angle closure glaucoma. Secondly, I mentioned that those who have hypermetropia, those who are short-sighted are more prone, those who are long-sighted, that's hypermetropic patients, are more prone to primary angle closure glaucoma, while those who are myopic, those who are short-sighted, are more prone to the open angle glaucoma. Now, I mentioned that the ladies, the women, also have, narrow angles than the men. And so more women will come down with primary angle closure glaucoma than men. And I said the aging too, as people age, their angles narrow. So you see people, the age onset glaucoma, older people coming up with primary angle closure glaucoma than the younger ones, So almost like if you say young person, the angle is almost likely to be open, But you see, do the needful. You don't say it is like a rule. No, you must always check the angles.
All right. All right. And from these types that we have listed above, which is the most dangerous or the fastest in causing vision loss?
Okay, so the fastest in causing vision loss is the primary angle closure glaucoma. It is actually the one that comes up with pain, and that pain is, yes, the patient comes with pain, but it is also a helping factor. Do you understand? And it's the one that can come up aggressively. Aggressively in the sense that somebody who is supposedly okay may come into a dim light, and when the patient comes into a dim light, the pupils dilate. Like if you come into a place that is well lit, a place that is bright, pupils constrict. They come together. So when the pupils constrict, they tend to open up the angles. But when the pupils in a dimly lit room, the pupils dilate, and when they dilate, they clog the angle, because it is, where would they stay now? It is only the angle that they have space to stay. Do you understand? So they tend to increase the angle. So in some patients who already have primary angle closure glaucoma or spike, may not understand, may not know until they come into a place that is dimly lit, and then the pupils dilate, and then the pressures get raised beyond their imagination, and then starts causing pain, and then they start seeing colors around light, and their vision drops, So this patient, this is what called acute angle closure glaucoma. Is the acuteness, and the patient comes that his vision has gone down, the eyes are red, are inflamed, and if you now do, in some cases, the pupils, the cornea becomes hazy because of the corneal edema, and when it's edematous, it's hazy. So what you do is that you do what we call gonioscopy. Gonioscopy is the act of assessing the angles, the anterior chamber angles. So you do a gonioscopy on the other eye, and once it is narrow, the diagnosis is obvious that this is an acute angle closure glaucoma. Then the patient is now treated appropriately. You have to bring the patient over the time. As I'm bringing down the pressure, you're also calming down the inflammation, and then trying to see if you can pull out the iris from that clogged angle. So this is what happens, and so that is why it is quite dangerous. That it can cause, and then some people will have pain and be taking paracetamol, and don't know that something sinister is happening. The pressure is going up and causing pain, and they're like, don't worry, it is just typhoid or it is malaria, and they're taking these drugs and not coming to see a specialist, except somebody tells them, if it is from the eye now, the headache, go and see an ophthalmologist now. And they come when it is, in some cases they vomit, they get nauseated and start vomiting. The headache is pounding because the pressures are quite raised. So you are doing your best to bring the pressure down, reduce inflammation, and then see if you can get the angles opened again for drainage.
All right. Taking this discussion further, ladies and gentlemen, if you're just joining, it is Glaucoma on Radio right here on Solid 100.9 FM. Chibika James as well as Dr. Obina Shiwobi. And right here today we are discussing, the different types of glaucoma, and also looking at the dangers that are involved with this type of glaucoma. And yes, we have been able to explain what glaucoma is all about. We have talked about the types, which are the open angle glaucoma and the closed angle closure glaucoma. We have talked about which of these glaucoma is most common in Nigeria, and which one is more dangerous and faster in causing vision loss. Let's take this conversation further to the symptoms and the warning signs. Yes, we say it is a silent thief of sight, but I'm sure there are gonna be some symptoms that one could look out for to ascertain and know if he or she have glaucoma. Now, Doc, I would like to know, do these different types of glaucoma present different symptoms, or they just have one symptoms, and once you see it, just know you need to go to the hospital?
Okay, thank you, Chibike. So by what we say that glaucoma is litany of eye diseases that have there are common factors that affect the optic nerve. So because they are different disease entities, they also have different symptoms and then different signs. For the commonest one, the primary open angle glaucoma, I said earlier, this is a very deceitful disease. And when they ask me, what are the symptoms? I keep saying, there are no early symptoms. If you're waiting for early symptoms, you are deceived. So the best thing is for people who should do annual checkup. Having said that, when they also have some symptoms, like they have blurring of vision, and by this time the disease is not established, and then you find out that they have a blurred vision, and they notice that they're beginning to, as they move around the same environment they've known years, they begin to bump into objects, bump into chairs, bump into tables. Do you understand? Somebody will say, Daddy, are you not seeing this thing now? He said, sorry, my son, At that stage, you say that, he's having blurry vision. Another important symptom is frequent change of spectacles, frequent change of glasses. Now, when these patients who have glaucoma begin to patronize roadside opticians who give glasses, who do not understand the disease entity that the patient is going through. So what they do is that they can refracture the moment, improve your vision. Then less than 3 months, less than 6 months, you find out that same glasses is no longer doing well again. You run back to the same person. He gives you another spectacles. Less than 6 months, you find out that this same glasses is something is wrong. Go and see an ophthalmologist. You are not treating the patient. The optician is treating the symptoms and not treating the disease itself. And that's why these patients come every time they're changing glasses. And then to them is a routine. You come, change glasses, and then the man makes his money. So, but you should ask for a second opinion. Seek somebody else. Don't. So it also happens. Then when they now notice that their peripheral vision is getting constricted. That is, they don't see things that on the periphery except they look straight at it, because the last vision to go is the central vision, and that's why it's a deceit. Many of us, even if somebody calls you by the side, you have to turn your head to see the person. So you don't even know that your field of vision is going down. And on this particular radio, and I've said people should learn to check your eyes. There's a target about, say, 6 meters away. Close one eye, look at it. Then after 5 seconds, close the other eye and look at it. Because many a time the disease is asymmetric. Asymmetric in the sense that one eye is dying, but because the other eye overlaps into the visual field of the other, it seems as if the patient is doing well. Now let me give you an example. A patient came and said, I drove from Enugu to Umahia. When I got into Umahia, I wasn't seeing with one eye. So what happened? He has glaucoma. He never knew. Now one eye was going down. He never knew. Now when the better eye covers for the other one, because it extends into the visual field of the other one, patient feels that he or she is seeing very well. Now when that particular better eye starts going down, our Igbos say, Ufuanya jisi ugwo. It tells you that the Igbos knew about this disease even before we came to be, because that is a common saying. It was actually what happened with glaucoma. One eye goes first, then the seeing one patient is happy. Not, before you know it, that same one that is seeing starts depreciating, and before you could say Jack Robinson, it goes. So the saying, Ufuanya jisi ugwo. The single eye that owes blindness, that blindness will still come. But with advent of science and where we are now, such things don't happen anymore for those who visit an ophthalmologist. But so that's the truth. So having said this, so the primary open angle glaucoma's symptoms come late, and I mentioned they start with blurring of vision, both for distance and for near, for reading. It also starts with bumping into objects, and they notice that their peripheral vision is narrow, and then some of them begins to see, in some cases when the pressures are built up, can begin to see what you call floaters, in their eyes. Now compare it to angle closure glaucoma, because the angles are closed, and before you know it, the pressures build up faster, not like that of a primary open angle. The primary open angle, the pressure builds up gradually, and it's a common cause of painless gradual diminution of vision. Now, for the primary angle closure glaucoma, patients, the pressure builds up faster, and then because it builds up faster, it affects the cornea. The cornea gets hazy and edematous, and then there's pain. Now the primary angle closure glaucoma in Nigerian setting, in African setting, can also happen like that of the primary open angle. Yes, many of them come up with like the primary open angle glaucoma, like all I have said about blurring of vision, about bumping into objects. Just that they may come up with pain and discomfort. And then they notice that whenever they enter in a dimly lit space or room, that they tend to see the pressures build up, and then they see, when they look at bright lights after that, they see rainbows around lights. And theirs is dramatic. you know. So this the changes. But like I said, the most important thing is that every patient should have everybody should have his or her eyes checked, because that quick diagnosis, that early diagnosis, the beauty of angle closure glaucoma is that if caught on time, for somebody who comes for regular checkup and that you find out that, oh, these angles are closed though, and then you offer the patient laser peripheral reductomy, that means patient will not come down with glaucoma.
Interesting.
Yes, the patient will not come down with glaucoma, you know, or even if the patient will come down with glaucoma, you have already started a good job because you have already opened angle. No, so that mechanism of glaucoma formation should have been angle closure, but now the angles are open by virtue of what you have done. So in that case, you are actually preventing you're actually doing a good job of, not patient coming up with the aggressive rise in trochlear pressures.
All right, well, ladies and gentlemen, yes, we're discussing one name, different dangers, and we're talking about the types of glaucoma. Chibika James as well as Dr. Obina Shiwobi. All right, now let's open up the phone lines and take your calls. We see your calls already, so feel free to call us now if you've got questions regarding what we are talking about. So the numbers are 0704 550 2840, 0909 771 1009. And you can also call 0902 311 1009. Hello, good morning to you.
Good morning, Chibika James.
Yes, good morning.
Good morning, Dr. Vietnam.
Good morning, sir.
From now.
What did you say?
Yes. Dr. Vietnam, I just know that you know that the way to pay out.
Can you hear me? Your line is breaking.
Hello?
Go on.
Can you?
All right, maybe you call us back 0704 550 2840, 0909 771 1009, and you can also call 0902 311 1009. Okay, these are the numbers for you to call to be part of the program this morning. Hello, good morning to you.
Good morning from.
Yes, good morning.
Yes. Good morning, Dr. Vietnam.
Good morning, sir.
Yes, Dr. Vietnam, into your office once at a time. I thank you very seriously for good work you are doing. Yes, I thank you very much. May God continue blessing you. You are very solid, firm workers and the management.
Bless you too, sir.
The picture about
Thank you.
There's nothing happened. Nothing. Somebody may have witnessed in his life. Okay. Every time they use people like the first time, it's not that so well using it.
I'm sorry, I have to let you go. We are really struggling to understand what you're saying. Maybe you move away from where you are and call us back. But Doc, let's continue having our conversation right here in the studio. Yes, we have talked about the types. We talked about the differences. Now let's go to the symptoms and warning signs. Now, in as much as we have highlighted the two types of glaucomas that we have, do different types of glaucoma present different symptoms?
Yes, sir. Because that's what we just said earlier. We talked about the angle closure and then for the congenital glaucomas.
Doc, hold on. Let's take this call. Hello, good morning.
Hello, Chief, good morning.
Yes, good morning.
All right, my name is Mark. Mark Oscar from Anambra.
Go on.
Just one quick question, sir. Now, are there any stage in glaucoma that somebody could be somehow permanently cured by taking cod oil or yeast tablets? Because I think you mentioned something like that now. There's one of my friends, he told me yesterday that he has some kind of blur vision. Yeast tablets and they called it lawyer, that you could not see some tiny object, better than before. So I want to ask, what stage can this actually be, helpful at any stage in glaucoma patient?
Oh, right. All right, Mark Oscar. Doc, you got the question correctly?
Yes, I got it.
All right, let's see if we can add another call so that you get to answer the questions together, okay? 0704550280 0909-771-1009. Hello, good morning to you.
Good morning, Chidike.
Yes, good morning, sir.
Joseph from Transecool.
Welcome, Joseph.
My regards to the doctor, please.
Good morning, sir.
I'm a glaucoma patient. So, and I want to know, let me come down, explain that blazer. Don't know the meaning of blazer. And please, can you tell me the dose I'm putting Timonol? Can he help me to know the best eye drop I can be putting?
Okay.
So, I'm putting Timonol and Galapam times when the pressure is high. So please, I need more clarification from him. The best eye drop and the blazer. Don't know the meaning of blazer. Thank you.
All right. Thank you very much. Well, Doc, trying to get prescription from the phone.
Yeah, it's okay. That's good. That's nice. Okay, so what Mark asked about stage in glaucoma where cod liver oil yeast can help cure glaucoma.
Yeah.
Okay, so let me state it here categorically clear that glaucoma is not curable.
It doesn't disappear once it's there.
Is not curable, but glaucoma is treatable. Treatable in the sense that when you come, the doctor's work is to protect what he came with. Now, for somebody who comes in advanced stage, he cannot. I said it is not curable and it is irreversible, and that's why for those who are placed on medications, must be consistent with their medications. It is like eating. You won't say you ate well yesterday, and therefore in the next 1 week you don't eat your food, then you look good. No. So you use your drug consistently. If you ate well yesterday, please eat well today, eat well tomorrow, and then you keep looking good. So same thing with this same disease called glaucoma. If you are placed on medication, then you must be consistent with your medications, and then it must be reviewed every 2 months, every 3 months, every 4 months, in some cases every month, depending on how well you are doing. And very importantly, depending on your compliance to medications. Very importantly, so cod liver oil, yeast do not. The yeast all helps in vitamin A production. For somebody who is well nourished, they don't play any role. Now, yes, it's good to have cod liver oil. I mean, they provide minerals, they also provide nourishment. Now, it's good to have them, but they do not add to the treatment of glaucoma. Now, what happens is that, you see, there is this psychology in what we do. If somebody believes in a particular thing, he feels that if I do this, I will see well. And he feels it is good, he does it and he sees well, and then not that he sees as per somebody who is visually impaired is not see. No, like I said, these things are adjuncts to the treatment. You can have your cod liver, can have a yeast. They are adjuncts in the sense that if you have glaucoma, you must be treated for glaucoma and not be given only cod liver oil and yeast. No, you will go blind. So now you can have it for somebody who does not have glaucoma, who does not have any issue. Yes, you can have them because they also offer you fats, minerals, and vitamins. That's good. They also help in nourishment and production of vitamin A, which also helps in structures both of the eye and the entire body. Good. So you can take them. But when it comes to eye conditions, those eye conditions must be appropriately diagnosed and treated. So at no stage in glaucoma does it offer cure. It does not offer any cure. Like I say, glaucoma is an irreversible disease and it is not curable.
All right.
But it is treatable. If we go to Joseph's case, do you have another question before I answer Joseph?
No, just go on.
Yeah, okay. So now Joseph asked about lasers. Laser is an acronym. It is a parasurgical therapeutic option that we offer to patients, and it is non-invasive. It is very safe. Very safe is that very safe and does not have much, side effects.
Yeah.
So when patients are afraid of surgery, please come. We offer you lasers. Even lasers can be offered now. The current trend is that you offer laser first. You use it to hit the trabecular meshwork on the angle. When you hit it, you tend to open it up more because it creates a little inflammation at the macrophages. There will engulf the large proteins, and then this tends to open up the angle. And then having done that, it means that it ensures more drainage. And then doing that, it means that the intraocular pressure will come lower. Now, when the pressure is safe, it means that there won't be further damage to the optic disc, the optic nerve. So, lasers are quite, and it is now here in Enugu. So it can be offered, yes, laser therapy. I told you about laser reductectomy.
Yeah.
Yes, it's done. You can also do laser capsulotomy. You can also do selective laser trabeculoplasty, which is a treatment option for glaucoma. And in the white world, in the Western world, it is offered as a first, choice of treatment, because once done, achieved, patient is happy.
It was also asking about the kind of drops.
Yes. So,
is it not best he comes for proper checkup to ascertain that?
Yes. So having said that, James Joseph, I can't talk about timolol, which is a beta blocker and it is an anti-glaucoma medication. Your Nezalata, which is a prostaglandin analog, which is also very good for treatment of glaucoma. Now, but we can only talk about how well you are doing only when you are well assessed. We can't talk in isolation of your assessments. I've not seen your eyes. I don't know your pressure. I don't know your cup disc ratio. I don't know your angles. I don't know your visual fields. And I also do not know what your retinal fiber layer is saying. So these are things we factor in. I also, before we make a scientific or proper discussion on glaucoma. Having said this, these two drugs are being used, but I don't know, are they controlling your pressures? That is so important. Now you're using it, are your vision still going down or your visions are maintained? This can only come when you are well taken care of and well assessed, not just being given these drugs, and then when you're on medication, we also keep assessing you to be sure that despite these medications that we have placed you on, are you doing well? Are we maintaining your vision the way it should? By checking your visual acuity, by checking your central visual field, these are parameters. Then looking at your retinal fiber layer, and also looking at your angles. These are parameters we use to assess to say we are doing well.
All right.
Pressure is maintained and vision is maintained.
All right. Let's take one final call before we wrap up. Hello. Good morning.
All right, so Chibike, sorry for your time. I know you're running out of time. My name is Mark. I speak back.
Okay.
Thank you, doctor, for the clear explanation.
Yeah, welcome, Mark.
Sorry, please, one question. Anybody said from apart from glaucoma, maybe general eye problem and include glaucoma included as well. Does alcohol intake, constant and too much alcohol intake, play any negative role on anybody suffering from any kind of eye problem? I know I'm saying because I have an uncle who just went for surgery at OG. He went for surgery. He came back, man, the way he takes alcohol, Palamo, Kaikayo, Tropio, in fact, in a day, he might consume more than 10 bottles. And I keep wondering, does it not going to affect, it doesn't affect or damage the eye more? I just want to know from you, doctor, please. Thank you.
Thank you, Mark. Okay, for those, you use the word excess alcohol intake. We have no issues with people who take beverage alcohol, stout, beers, and take them in let's say a bottle to not much. These things are helpful. But when you start going to serious alcohols like spirits, will become very suspicious. I mean, very uncomfortable, because it has been known and established that these spirits also on their own, cause optic neuropathy. And if this cause optic neuropathy, which is also what glaucoma causes, it means for somebody who has glaucoma, it is worse.
Or even any eye issue.
Any eye issue is worse, because you have multiple things affecting the eyes. Not only the disease condition, but also the additional abuse of alcohol. Because what I would say this is an abuse. From what he has said, there's an abuse. And then I think it's also good, lifestyle balance. We've discussed about lifestyle of a glaucoma patient here. What are people should know and what are people should avoid. The kind of food they should eat, and then take alcohol in very responsible ways. And then avoid the spirits that's in quantities that are very destructive to one's health.
All right, Doc. Just before we wrap up, Doc, in a minute or two, just summarize and tell us more about these lifestyle choices that we should go for.
Thank you so much. Okay, so just to say that it is established that glaucoma is an irreversible disease. Glaucoma is not curable. Glaucoma nonabani. Glaucoma is here with us. And we've talked about everybody having his eyes checked.
Yeah.
If there's a family history of glaucoma, that more reason why it should even come up. As you get 40 and above, that's the reason why it should even come up. If you are using glasses, if you are myopic, that is, you are short-sighted, that's the one other reason why you should come, because the risk factor for glaucoma. Having said this, all of us here, we are all blacks, except for one or two Caucasians that are in our midst. The fact that you are a black man, the fact that you are even an Igbo person is a risk factor to glaucoma, because it will find to be commonest among us. And then just to say that it is, people say something must kill a man, but it becomes painful when that thing that killed a man should have been prevented or had a preventable cause. And so that we say, if you have a checkup and you're found to have glaucoma, that means the blindness, the visual impairment, it will be prevented. But if you don't and you come down blind, that is the most expensive thing in life. And we have agreed, it's scientifically proven, that once you go blind, the lifespan of that particular person drops dramatically. That is the truth. So people, darling.
All right, thank you very much, Doc, for your very insightful analysis and explanation. And to all those who tried to reach us but couldn't, we say thank you to you as well. And yes, this program, Glaucoma on Radio, is championed by the Eye Specialist Hospital, Tesh Enugu, as well as Solid 100.9 FM. It will make a return same time, same station next week, Friday, 9 till 10 a.m. Do have yourself a blessed weekend.